Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 29, Virtual Care in the COVID-19 Era, Enabled with Enterprise-Wide Analytics. It will be presented by Patrick McGill, Executive Vice President, Chief Analytics Officer, Community Health Network. Enjoy the session.
Thank you. Welcome to the session today to discuss virtual care in the COVID-19 era and how Community Health Network enabled enterprise analytics to really understand and drive that transition to virtual care. So we'll start today with the agenda, and the first item is to review the learning objectives. We'll discuss the impact of COVID-19 on ambulatory visits. I think everybody has probably experienced similar to what Community Health Network has in terms of ambulatory care and how the COVID-19 pandemic has impacted their care delivery. We'll understand how enterprise analytics are critical for a financially successful practice and how even before COVID-19, having enterprise-wide analytics was critical and necessary to have a financially successful and healthy practice moving forward. And then finally, we'll share how Community Health Network rapidly shifted from virtual care from an in-person model and how we're measuring virtual care with an analytics platform, and then discuss what the future of virtual health and telemedicine looks like at Community and potentially across the country as well. To start, let's look at the learning objectives. The first one is to be able to verbalize the impact of COVID-19 on telehealth. We will also state how organizations can measure virtual care with an analytics platform, and then we'll demonstrate the importance of enterprise analytics for an effective practice management, whether it's in a COVID pandemic or not. So who is Community Health Network? Community Health Network is an integrated healthcare system in central Indiana with more than 1,100 employed providers, 9 hospital sites throughout central Indiana, 5 main hospital campuses with rehab and behavioral health as well. We have 13 ambulatory pavilions and 200 primary care providers and over 80 sites of care. It represents about 25% of the market share across the 10-county central Indiana district. So what has been COVID-19's impact on ambulatory visits? Early in the pandemic, many state governors and CMS called for stopping or reducing any non-essential or non-critical care in an effort to preserve PPE. I think many practices closed because the providers were scared, the patients were scared. We weren't sure exactly how to deal with this new novel virus that no one else had seen that was quickly spreading across the country. We heard horror stories from what was going on in Europe and the overrunning of the systems and the healthcare systems. And so there was a rapid shift or a rapid change to shut down care delivery. But that didn't mean that patients didn't need healthcare. They still had the same healthcare needs that they had prior to the pandemic. They still have diabetes and heart disease and other things that needed to be managed. We also knew that the number of ambulatory visits quickly declined by greater than 60%. Some studies showed it was closer to 80 or 90% of the ambulatory visits that were stopped. And so that represented patients going without care and going without having their needs addressed. In a study from Health Affairs that was published in May of this year, it showed that many practices were anticipated to lose almost $70,000 per full-time physician. And we know that primary care is one of those practices or one of those specialties that typically doesn't make money. And so it was critical to mitigate the losses very quickly and as fast as possible so that the situation didn't get worse. And so by May 2020, there was a rebound that occurred, and we continue to see that rebound today. But still, 1/3 of visits are done virtually. And so how do you measure the impact on the healthcare system when that percentage and that volume of visits are done virtually? At Community, we experienced almost a 92% drop in ambulatory visits, face-to-face ambulatory visits, as we saw this shift to virtual care throughout the pandemic. And that has continued. And we'll show later in the presentation, we'll show some dashboards and information on how virtual care has continued to stick and how we're potentially losing some ground. So how we want to continue to measure that. Enterprise analytics are critical for an effective pandemic response. The Office of Network Analytics at Community quickly stood up many different dashboards as it related to the COVID-19 pandemic. The number of patients who were testing positive, who was testing, the demographics, how many inpatient visits were we experiencing, ICU volumes, etc. And so many organizations needed the same type of information to be able to run their business and be effective and anticipate things like PPE shortages or other ventilator shortages. And so that was no different in the ambulatory setting. And so many outdated rules and regulations made it difficult to transition to virtual care and deliver care that was necessary in a virtual video or telephonic manner. And so quickly and early in the pandemic, many of the rules, the CMS and the health insurance payers updated the rules to allow the same type of reimbursement for in-person care and virtual care. And practices needed the technology solutions. At Community, we were under the gun like many other systems. We had not adopted virtual care across the enterprise. We had a few practices that were experimenting with it, but we were in no shape to be able to launch a video or telephonic platform across the entire enterprise. And so we quickly had to shift, not only from a patient standpoint and a care delivery, but from a technology and infrastructure standpoint as well. This slide is really our North Star and our guiding principles as it comes to practice management and effective practice management. So as you'll see across the top, outcomes are really a result of revenue acceleration, whether that's fee for service, fee for value, and then reducing your expenses. And so as we shifted and looked at virtual care, we really viewed those as patient access and revenue acceleration or mitigating revenue losses. Provider productivity falls in the fee for service revenue, and patient panel management falls in the fee for value. And we'll discuss those later on in the presentation, but it was really measuring the outcomes, measuring patient experience, measuring the high value and appropriate care with the as we shifted to virtual care, and then also trying to reduce the expenses to be able to have an effective and successful practice management. Prior to the pandemic, we had spent many months building a robust analytics suite of tools for the ambulatory setting. We really took the approach that we should be able to measure down to the provider as an independent business, going back to the way things, quote unquote, used to be when many primary care providers were independent practitioners. How would they run their business? And so building a suite of tools that people could look at to really run their practice as a business. And so we looked at things like, we built out tools and looked at things like income statements and productivity, access, how quickly were patients able to get into the provider, how long did it take for a new patient to get in, what was the lead time, what was the no-show and cancellation rate. As you know, that when you have a full schedule and you have 3, 4, 5 no-shows a day, that can really be detrimental to a practice's financial performance and limit access to other patients as well. So what was the cost and overhead for each physician in practice? How well did we do collecting the revenues on the rev cycle side and the contract and payer rates? So we had these tools in place prior to the pandemic. We had spent quite a bit of time building these out, validating the data, working with the practices and the providers to understand what would they want and need to be able to successfully manage and run a practice. And so it was, we had the foundation and the base to be able to build and shift to a virtual care, to understand the impact of shifting to a virtual care delivery model. Early in the pandemic, within the first couple weeks, we had to go from a nearly 100% in-person delivery model to a nearly 100% virtual care model. And so that meant things like e-visits and e-consults, asynchronous visits, on-demand 24/7 visits, scheduled video visits and follow-ups. And so we really tried to take a complete approach to address all the needs that patients might have. And again, we had some of those tools in place, but many of others we were building literally on the fly as we were going early in the pandemic. So what is the future of virtual care? I think this is a question that many people are asking, many organizations are asking, many patients are asking, and I think that as the pandemic continues to evolve, I think we as a broader healthcare system really need to address what role does virtual care play in our health delivery across the country. And so that starts, many times the argument starts with reimbursement. And so the reimbursement parity for in-person versus virtual visits is fundamental to continue the stickiness and utilization and adoption of virtual care. Telehealth becomes an essential component for basic patient engagement. I believe that patients want to interact with the healthcare system the way they interact with in many other aspects of their life. So as we've shifted to contactless grocery shopping or other types of shopping and other aspects of our life, we want and we desire and we see how that can function in healthcare. And patients are going to want that stickiness to continue. What care pathways or how do care pathways need to change as we shift to a virtual care delivery model? And so the way we do things in person is not the way we do things virtually, and we need to be able to understand and add training and protocols and different workflows in the EMR to be able to measure and deliver that care efficiently. And finally, it redefines our competition. In an in-person model, your competition is the practice, physician, or health system down the street. In a virtual model, it could be anywhere, anyone across the country that can deliver that. And it could even be a competition that's digital, artificial intelligence. Those types of things come into play as well as people want and seek that care on demand when it's convenient for them. And so I think that we have to really be thoughtful and mindful about what the future of virtual care and telemedicine looks like, and how do we weave that and integrate that with our current model prior to the pandemic. As we made a shift to virtual care, as I mentioned earlier, we had to shift our analytics. So we had a robust practice management suite that was built on in-person care. And so this is a screenshot from a dashboard, from a suite of tools that we built to measure virtual care and be able to show the impact of that care on our practices. And so you'll see on the left-hand side, you're able to filter down by specialty, whether it's primary care or specialty care, down to family medicine, internal medicine, even down into the department, so the specific practice, and all the way down into the individual provider. So you'll see in the middle, it shows that early in the pandemic, as I said before, we had almost no adoption of virtual care. And then as the pandemic started, we ramped up telephone visits, which are represented by the gray bars. The telephone visits were so heavy because we didn't have that video visit technology and the infrastructure to be able to do that. As we shifted quickly over the month of March, you'll see the blue bars start to grow, and as the reimbursement shifted, you'll see that more people started adopting the video visit technology to deliver the care. And so it's interesting how you'll see the analytics really mirror what happened in real life. As things shifted quickly, we adopted telephone visits, and then as the video technology quickly ramped up, you'll see this shift, and hopefully we see some of that shift become sticky and be able to be measured long term, or be able to be continued long term as we shift our care delivery. Down at the bottom, you're also able to see, as you filter by practice and specialty, actually how many visits were performed, how many were completed. So it allowed us to be able to measure some of the technology changes that needed to be made. If patients were starting in a video visit but it wasn't completed because the technology was dropped or other barriers to that patient engagement. So it allowed us to quickly see who was adopting the technology, who was struggling, whether that was from a patient standpoint or a provider standpoint. As always, you have to understand the revenue impact on many of these changes. And so we built a scenario tool that allowed practices and providers and leadership to be able to play with different scenarios on virtual care and virtual health adoption. So it allowed you to understand if you performed a certain percentage of virtual visits, how would that impact your revenue? If a certain percentage of visits were reimbursed or not reimbursed, how would that impact? And so on the left-hand side, you can see there's different start dates and reimbursement rates and other scenarios that can be toggled or adjusted to be able to see the impact in real time on what the financial performance of either the practice, the department, or even the network might be under different changing and rapidly changing situations. Health equity, this has been a big topic lately. It's been around for a long time. Many people have been discussing health equity, and with many of the changes in society, people have been looking at health equity. We were no different. So we wanted to understand the impact on health equity, virtual care on health equity. So are certain populations being disadvantaged because they don't have reliable internet, they don't have smartphones? And so we broke this down by county and by race and ethnicity to understand, were certain populations not able to access care when we shifted to a virtual delivery model? We always know that people struggle with in-person model, struggle with getting care in an in-person model by whether it's transportation or being able to get to the doctor or just having resources available in their community, but does the same hold for virtual care? And so we broke this out by telephone, video, and then compared it to other populations and used the census data as a benchmark to really understand, are there certain populations that are being disadvantaged as we shift to virtual care? Luckily for us, the analysis was pretty consistent that there was not a population that was being disadvantaged, but it continues to warrant further evaluation and looking at. These represent patients who had interacted with the healthcare system. So is there a population of patients who have just not even interacted with the healthcare system because they don't have the technology? So there is some inherent bias in this analysis. However, we as an organization are committed to continuing to look further and break down those barriers as it relates to health equity and outcomes, whether it's in person or virtual. What does the future of telehealth look like? And so how do we go forward? Many providers have been asking, what percentage of visits should I perform virtually moving forward? And so we created a scenario tool that allows providers and practice management, practice leaders and others to go in and pick by visit type. If I do this visit type virtually moving forward, how does this impact my total visits, or what's the percentage of total visits that could be done virtually moving forward? It allows us to plan different scenarios from a reimbursement or revenue or staffing or workflows. And so it does allow people to not necessarily make the clinical decisions on what visits should be done virtually. It allows a provider to go in and say, if I do these visits virtually, this is what the impact is on my schedule, on the number of visits that I perform in person and then digitally. So it has been helpful as we look to what the future holds with virtual care and create that stickiness. Many people want to shift back to the way it was before the pandemic. They're used to in-person care. It's the way they've always received and delivered care. It's comfortable to them. And so as we try and move that comfort zone, this is a tool that allows people to look at that and make some educated decisions on the types of visits that should be virtual moving forward. This tool has been very helpful and been very welcomed by many providers because it helps mitigate some of that unknown of what the future looks like. It allows them to decide and look at what the future could look like for them. And again, not a top-down approach, but a bottom-up of these visit types could be delivered virtually. This has been very well received by many of the providers. As I mentioned earlier, we had a robust suite of tools prior to the pandemic. It was built mostly on a productivity or work RVU basis. This is an example of a productivity summary that every physician, every provider in our organization has access to. It shows by practice down to the provider what the volumes have been, how many work RVUs they perform, what the anticipated collections is, and then what the impact is on their income. We still are in a work RVU fee-for-service compensation model, and so it allows providers to understand the differences of workflow and the differences in volumes and how that will impact their income. You can see in the upper left-hand corner, it shows the number of days worked, how many visits they performed a day, how many work RVUs per visit, and how many unfilled slots a day. On a separate screen that's not shown here, it allows also scenarios to be adjusted so that if they work another day a month, or if they add another couple visits per day, if they were able to reduce their unfilled slots a day, what the impact would be. And these changes are calculated in real time. So it allows people to really see if I add another visit, or I work another hour, or I maybe add another half day of clinic, this is what the impact will be on my work RVUs, on my access, on my patient experience, on my productivity, and then ultimately on their income. In the middle, you'll see the schedule heat map. So it allows people to see when the high demand times are during the day. So if they see a lot of demand, the slots go filled early in the morning, they might add extra hours in the morning. If they see some gaps in the afternoon or in the middle of the day, they might fill in virtual visits during then. So this was a suite of tools that really, while it was built for an in-person model, it really allowed us to shift. When we shifted virtually, allowed us to fill in those gaps with virtual tools and allowed the practices to adjust their workflows and their practice management to drive some of that virtual care adoption. Patient panel management. In Indiana, we're still primarily fee-for-service, and I know that's different in a lot of parts of the country. So as we shift to more of a value-based care model, we've been shifting or discussing and trying to shift away from a primarily work RVU model into a panel management. So managing the entire suite or managing the entire patient panel, not just the transactions. And so this tool allows people to look at panel counts, and this goes down to the provider again. It allows them to see what their weighted panel is. So being adjusted for age and gender and payer, they can see what their entire weighted panel might be that they have to manage. It also shows what the growth of their panel might be. So how many new patients are they seeing? How many patients are being lost off their panel because they haven't been seen in 2 years? And so this view allows people to really target outreach for patients and maybe leverage the virtual care tools that we have now to outreach and interact with people who would not be coming into the office, but we don't want to lose them out of the network or to another provider. It shows by region, by department, down to the provider, different things like payer mix and attribution rates, and then you can break that down by value-based contracts. So you can see, is there one practice that's heavily weighted with one payer versus another, and maybe we need to redirect or shift resources to help with that contract, to help manage the performance of that contract. Lost patients has been a topic that we've been discussing for quite some time because, as you understand, patients who are lost to the network, they might be receiving care somewhere else. And so how do we create the stickiness as an organization, the stickiness to the network, and again, leverage some of those virtual tools, whether it's e-visit or a video visit, to continue to interact with that patient. And so this allows, you'll see the off-panel and at-risk, this allows people to really track and manage how many patients are falling off their panel, who's at risk to fall off their panel, so that it gives them a prioritization to really outreach, close those quality gaps, close the gaps that patients might have in their care, and really create that long-term relationship and the stickiness with the patient. So what are the results? In just 1 week, Community Health Network deployed COVID-19 virtual care, virtual visit analytic tools. including that robust scenario planning. So again, we had the foundation with the practice management application, and we were able to quickly transition and shift to including virtual care into that suite of tools. And that's been tremendously helpful during this uncertain time of reopening and closing and reopening again. Virtual visits now comprise about 80% of all of our visits. That number it continues to decline. We hope that we can create some stickiness with many of the tools and options, and we hope that patients will desire and create some of that stickiness. But we did see this quick ramp up on virtual care, and in 1 month we saw approximately 40,000 visits, which was almost as many as we saw face-to-face prior to the pandemic. Leveraging these virtual care options and powered by the suite of analytics that was built, Community was able to maintain 75% of its ambulatory outpatient revenue, which was very helpful during the uncertain time of closing down during the pandemic. Finally, what are those key learnings and recommendations moving forward? So enterprise analytics are critical for effective practice management. Think back to the equation that we showed of outcomes based on revenue and reducing expenses. Having insights into each one of those buckets is incredibly helpful, not only from an organizational standpoint, but you have to have it down to the practice and the provider level. Having it at the provider level really drives that engagement and the adoption of the tools. Having it at the provider level allows people to adjust behaviors, adjust practices, adjust pathways and workflows in the office to optimize all of those, whether it's patient outcomes, patient experience, reducing expenses, or really optimizing the revenue. So having an enterprise suite that's drillable down to the provider is incredibly helpful and actually is foundational for effective practice management. The second item is, I think we would all agree that telehealth is here to stay. It requires us to think differently on many aspects: how we deliver care, how patients interact with the healthcare system, who our competition is. And so having an analytics suite that can help drive many of those questions and answers is incredibly helpful. And again, having it from an enterprise level down to the provider or practice level is also incredibly helpful as it comes to shifting resources and addressing needs in the practice. As we try and optimize expenses across the organization, it's very helpful to be able to shift. And so we have to think enterprise-wide versus just as a practice. And so it really requires us to think differently. It requires us to think differently on how we practice and how we also manage within the practice. The third item is that we need to rethink care pathways across the continuum. If we all agree that telehealth is here to stay, it requires us to rethink how we deliver that care. Who does what during a visit? What can we do prior to the visit? What can we leverage technology to do after the visit? How do we interact with people when they're in the hospital? How do we interact with people when they're out of the local area, maybe across the country? What are things that we do and what can we do? And so it really requires us to rethink care pathways across the continuum. And that continuum now expands outside the four walls of the practice or the hospital. It requires us to really think the entire continuum follows the patient no matter where they are. Finally, organizations need to really think about how telehealth fits into their strategy. So from a strategic standpoint, historically we might be looking at bricks and mortar. Where do we build a new practice? Where do we build a new hospital? Or where do we build another facility? And now it really requires us to think about where do we need to invest in digital technologies moving forward? How will patients want to interact with us moving forward? And what tools do they need, whether it's home monitoring or other items that they might need to interact with us, versus how do we want to interact with them? And so it allows us, it causes us to really shift and rethink what our operational strategy, what our people strategy is, what our care delivery strategy is moving forward. And that follows with many other operational decisions that need to be made. Where do we place capital investments? Where do we when we hire providers, where do we need to place them? Do we create a telehealth department that only focuses on virtual care versus in-person? in-person care? Is there another subspecialty that's necessary within an organization the size of community? And so these are some of the key learnings and recommendations that we experienced during the COVID-19 pandemic. And again, I'll say it one more time, having that enterprise analytic platform was critical to be able to shift and drive the success that we experienced with virtual care during the pandemic. Now we'll have time for some questions and answers.